traction with Zonta International and what they actually do globally for women was in Liberia immediately post-Ebola. Once most people got the clear in fall of 2014, once all the cases had died down, I was asked to come and help support fistula training in Liberia. And the training was primarily for the young surgeons in the OBGYN and surgical department in Liberia at the university. And what had happened was Liberia, after coming through a very long civil war, along with nation building and making health a priority, had also wanted to start postgraduate training. So they needed more doctors and they needed to train more doctors. They had a medical school, but if you wanted to be trained as a surgeon, as a pediatrician, as an OBGYN or anything else, you had to go actually either to Ghana, South Africa, to another country to get that training. So part of the mission, immediately before Ebola hit Liberia and decimated a lot of the healthcare structure, the mission was to train doctors in Liberia alone. And they started an OBGYN program, and basically a few months into it, everything came to a grinding halt. But there were 5 OBGYN residents, and the goal was that as part of their formalized training over 3 years, they would get obstetric fistula training. But I want to just go back a little bit and talk about our group, International Medical Response, or IMR. And we started the year before in 2013, and it was 3 of us who were healthcare workers who were really committed to health equity and justice and had done a fair amount of work in different settings internationally in areas of needs. And we came together with a common goal of creating partnerships and collaborations primarily focused on healthcare worker training. So as a gynecologic surgeon, as a pelvic reconstructive surgeon, my area of expertise is needed all over the world because not only fistula, but prolapse and incontinence is very, very prevalent. And yet most surgeons, OBGYNs or general surgeons, don't know how to take care of it surgically. And it's also estimated with obstetric fistula, which I think everybody has kind of a basic idea about, but it's a very severe birth trauma where women labor for days and then end up with a hole between either their bladder and vagina or rectum and vagina. And the treatment for this is surgical. The answer is obviously preventative, that we should have cesarean sections in an emergency situation where needed that can be safely done, but that's not the case. And as far as once you actually develop a fistula, surgical treatment is needed. And it's estimated about 2 million women suffer with fistula around the world, and that's a guesstimate, everybody's best guesstimate, because mostly this is silent suffering. People will self-segregate, women will hide themselves, they're stigmatized, they won't go to social events, they are often ostracized, but we find in most of our research that many of them just self-segregate, alone, withdraw from community, withdraw from religious services, withdraw from family, can't eat with their family or don't feel like they can. So that's a lot of women out there that need to be taken care of, and we estimate that 1 in 50 women who need surgery actually get it. And there's a few reasons for that. One is there's just not enough surgeons trained in how to do that. It used to be a problem here in the States, until the early 1900s, and now no more because we have emergency obstetric care. So it is a problem we know how to eradicate, yet we're dealing in situations where there are a lot of other factors at play as far as being able to provide quality health services. So our focus at IMR was really to work on health worker training, nursing training, community health worker training, and surgical training. We started in Liberia working with the National Fistula Program, which had great support from Zonta, UNFPA, the local country office, the Ministry of Health, and the medical school were all very involved. And I traveled 2 to 3 times a year to Liberia to continue on with the training of surgeons who are interested. And what we've seen is obviously the number of cases are going up of women who are getting treated, the awareness in the country is going up, and by our lecturing even to medical students and other healthcare providers, they have a much better understanding of where to refer women when they have these situations. We've also done newspaper outreach, radio outreach, at least to make people aware of how to prevent it and that treatment is available.